don't realize that the Census Bureau collected data on the mental health of Americans in their most recent edition. They discovered that more than half of Americans have significant experiences of sadness a couple of times a week. Moreover, about 1 in 4 feel that way most of the time. Also, the Center for Disease Control just published a study indicating that suicide is back on the rise after several years of decline. Who among us is not touched in one way or another by depression, which is the topic of our program today, Mental Health Matters. Hello, my name is Dr. David Palmer. I'm on the psychology faculty here at Marywood. I'd like to begin by introducing my panel of experts. To my immediate left is Dr. Stuart Badner, who is the director of our school psychology program here at Marywood and also provides a service to the community I'll tell you about at the end. Next to Dr. Badner is Dr. Matthew Schaefer, who's the director of our Psychological Services Center, also a private practitioner. And Dr. Schaefer is going to be talking with us today about a screening event about depression coming up in a short time. Next to Dr. Schaefer is Dr. Lauren Hazuri, who's an alum of our PsyD program here at Marywood and has a thriving practice in the Scranton area. And last but not least is our student representative for this edition, Sydney Skrutsky, who is a junior psychology major here at Marywood, who aspires to go on to graduate school later. Welcome, everybody. Thank you for coming.
Thank you.
All right, so why don't we talk, I mentioned some relatively recent stats about depression, but talk to us about how common these issues are, how much you see them in either the world at large or in your clinical work or teaching work that you do.
I know personally, recently, I found some statistics regarding major depressive disorders and episodes, and it was found that as of 2020, about 21 million adults are suffering from at least one major depressive disorder.
It's a big number.
Yeah.
It's a big number.
Certainly, anecdotally, running a community mental health clinic, probably behind anxiety, it's the most common disorder that we see. And anxiety and depression, of course, are not mutually exclusive. Kind of thinking of them as siblings rather than divergent disorders. They can commonly co-occur, but very frequently we have people that have, if not in the midst of a major depressive episode, they have that history and maybe presenting with more of agitation that looks more like anxiety.
And what you just said kind of mirrors the Census Bureau findings, where a little over 60% were suffering from anxiety a couple days a week, and about 1 in 3 most of the time.
And if we think about it, right, if we have depression on a continuum, all the way at the far end isn't suicidality, right? It's pure vegetative states. It's where you can't get out of bed, you can't engage in life activities. It's far too overwhelming. And at the extreme end, you have euphoria, right? So paradoxically, people can be sometimes more at risk as they start to look better, as they start to activate, as they experience more of that agitation and anxiety.
Dr. Benner, what about schools?
I was going to say that children and adolescents are not immune to depression either. And in fact, regarding your statistics regarding suicide and all that, suicide is the third leading cause of death for teens as well. So schools are very aware of depression, and it's something that we take very seriously. One of the things that schools offer are programs such as student assistance programs, also known as SAP, and that would be a program that can work with children and adolescents that are having mental health issues or issues with depression, and are keenly aware of any concerns regarding talks about suicide as well.
We're going to come back to that in a minute. What about you, Dr. Azir? What are you seeing?
Well, I think since the pandemic, I've seen a lot of people who maybe have been struggling even pre-pandemic, but they're a little bit more likely to reach out and get help now because it seems a little bit more normalized since COVID. That they think, okay, so maybe this is secondary to COVID, or there's a reason that's not just me that I'm feeling this way. And so I do see that a lot of people who maybe had been struggling even beforehand are reaching out and getting some help now. As you were talking about the schools, I was thinking I work primarily with adolescents, high school, college age, and something that I've noted, and I don't know if you see this as a student as well, but socially and emotionally, it seems that kids are kind of like developmentally lagged a little bit, and so my sophomores, kind of socially and emotionally, are more like seventh graders, but still they have the same expectations in the school. So it's, while schools, I think, really try to be understanding and recognize that, this is just a different time with different kinds of struggles, it's hard for the teachers who teach sophomores to see these sophomores who are, as actually maybe eighth grade socially and emotionally. And so kids are having a hard time with keeping up, and then they start to feel badly about themselves. And it's kind of like a domino effect I see. That, in the intro you mentioned sadness. And a lot of my kids are saying things like, I don't feel sad, but I feel empty. Or I don't feel anything at all. And so I think for people to recognize that sometimes depression doesn't feel like sadness. It can feel like just no energy. It's different for everybody.
So a lot of people who haven't had any personal experience with suicidal thoughts or feelings often wonder, like, how could someone ever get that way? How could someone ever want to end their life? How could that ever be a thing or make sense? So can you describe for our viewers what goes on in the mind and heart of someone who's thinking about suicide?
Sure. I think we're touching upon the hopelessness dynamic in particular, right? Even more than depression, right? Hopelessness is a more robust predictor of a future suicide attempt. And let's face it, some people have extraordinarily difficult life circumstances, right? I don't think we talk about enough of this, but during our training, right, there was a distinction between organic and reactive depression. Some people's depressive response to their everyday life stressors is not pathological, it's normative if one endures these things, right? And we can see that fairly easily, right? Someone who's in a chronic intimate partner violence situation that's been abused for multiple years. It's easy to see how someone would experience a certain degree of hopelessness, right? And recognizing that you don't jump right from fully neurotic interacting in your daily life to suicidal, right? Many people may experience life stressors where you're not suicidal, but you want to maybe go to sleep and sleep the day away, or go to sleep and not wake up. Some morbid type thinking. And then that morbid type thinking progresses and morphs to suicidality, largely influenced by, I believe, hopelessness as a huge construct. If we look at it through that continuum, it can be very easy to see. I firmly believe it. Myself, everyone on this panel, we're maybe 3 or 4 life stressors away from experiencing.
So a lot of pain with a feeling of it's not going to change.
Nailed it.
What else do you think goes on?
I've heard people explain it like very similar to grief, but the loss is of themselves, not somebody else. And so I think that oftentimes when people have what I mentioned earlier, that like lack of energy or just lack of motivation to do the things that they typically would like to do that would make them feel like themselves, since they don't have the energy or motivation to do those things, they don't even remember what it feels like to feel like themselves or to live. And so it's not like they want to end their life. Their life feels like it already ended. It's that they just don't want to do this anymore. They don't want to feel this pain anymore. So it's not, from what I understand, not necessarily I want to end my life. The life already feels like it's over.
For children, adolescents, while they may experience similar kinds of feelings, or that feelings of emptiness or sadness, profound sadness, sometimes it's masked by irritability or anger, frustration, noticeable changes in mood as well. So, which we wouldn't necessarily think of attributed to depression. So these are all things that teachers and parents can be aware of and check out.
Mistakenly think Johnny's just being a pain in the butt,
Right.
but it's really a
It
mood.
may be indicative of something deeper.
So let's talk a little bit. We started, Dr. Schaefer already mentioned anxiety is a common co-occurring problem. What other co-occurring problems do you see or you notice go along with mood problems?
Probably substance use disorders in a huge way. Maybe skewing a little bit more male than female traditionally, but with opioids coming onto the scene, it's becoming a lot more of a dual gender phenomenon.
Yeah, you get this flash of relief, brief
Yeah,
period of
it's very
relief from the
reinforcing.
pain. And a lot of people don't understand people abuse substances don't do it to feel good. They do it to stop feeling poorly.
Especially with opioids, you don't feel good really very often after that first initial.
Right, so I often think of it as like this mythic bird that carries someone out of the prison of their mind, carries them around a little bit, but then drops them back in from a great height. So they're worse off now than they were. Anything else you see that's a co-occurring?
You know, I feel like I preach about this much too often, but social media. You know, I think that a lot of my kids, when they're not feeling great, kind of just dive into their phones and into that like la la land in their hand, and become more and more isolated. And you know, the social comparison game starts, and then they start to feel really badly about themselves, and low self-esteem kicks in. And with that, then we see eating disorders and things like that. And so, you know, if any parents are watching, monitoring social media use is so important. Because I do see such a correlation with my high school and college kids.
Anything you notice Eddie, among college students, like how depression plays out?
Definitely, I'd say social media is a huge part of it. Even for myself, like sometimes I feel like I get caught in that comparison, not to the extent of like depression, but still it's so toxic. And even just feeling like you need to push yourself beyond your academic limit and just not having time for self-care is a big component that I've seen in so many people. And it's a downward spiral. And even that mixed with like addiction, alcohol addiction, like we were talking about. I know so many people who just drink to feel good and like stop feeling terrible. And it's like an endless loop.
So what about causes? People, I think, wonder like, well, what causes depression?
So I often think of three causes. So we have genetics, which we can't really do very much about. Then we have our environment. So I think of our environment as being everything in the world that's not us, and our lifestyle patterns. And so typically when somebody comes for care, once we do an evaluation process and kind of give some rating scales and things like that to get some objective measures, and come up with a diagnosis, then come up with a plan. At that point is when I start with lifestyle, which is eat, sleep, exercise. So those are always the first things to go. But as human beings, we need to care for ourselves physically if we want to feel good mentally. And so eat 3 meals, 2 snacks. We have to nourish our brain and our body. We need to get some movement in. So some movement for about 25 to 30 minutes a day. And that's not just, because, people often think exercise because I want to look good. No, exercise because we need to feel good. Because we get that boost in serotonin. Serotonin is the neurotransmitter in our brain that makes us feel good. And so research indicates that getting a half-hour cardio exercise can give us the same increase in serotonin as a low dose of an SSRI, like an antidepressant medication, a Zoloft or Prozac, something like that. So getting the meals in, getting exercise, and sleep, which you college students don't do a great job of. So getting 8 to 10 hours of sleep, which is recommended for you, is really important. So if we start with eat, sleep, exercise, that's the first cause of depression that we can really, we can manipulate pretty quickly.
Excellent response. I just think, again, we like to believe we're a lot further away from depressive symptomology than we actually are, right? It's an easy thought experiment. Imagine 46 years old, imagine today, you're middle aged, you're diagnosed with early onset Alzheimer's, and you're going to live the rest of your life as a burden to the people that you matter most. If you're not believing that you're going to entertain some level of suicidality, I think you're lying to yourself.
Dr. Bennett, there's just a misperception that comes up for parents about teenagers. I want you to react to the thought as well. He's captain of the football team. Everybody loves him. We provide everything he needs. How could he ever have thought about suicide? What would you say to that?
Well, certainly it's a combination of, as Dr. Zuri mentioned, depression also runs in families, the genetic component. Mm-hmm. So there may be a strong sense of biology here in playing, but also the environment. It may be associated with stress or pressure of performance and what's going on at home, in the community, within the family, how everyone's responding to the pressures and the stressors of being the star of the team. So what you often see, especially with kids, is not always what's happening underneath the surface. So you really have to pay attention to the warning signs and some of the things that may seem like they come out of nowhere. But if you pay a little bit closer attention, friends usually say, well, he's been a little bit more distracted lately, or parents are noticing changes in sleep patterns or eating patterns. So yeah, it's not an uncommon occurrence.
So if you're in paradise but you think you're in prison, you feel like you're in prison.
Correct.
If you're in prison and you think you're in paradise, you feel like you're in paradise. So we can't judge by the externals necessarily about that inner world.
It's a great point. There's also the distortion sometimes, I'll be happy when, right? And so that's why for Olympic athletes, if they win the gold medal, sometimes they'll be watched closely. Because Deion Sanders, a famous cornerback, he was playing for...
in the future,
Cowboys.
outside my control.
Yeah, right. And he had a suicide attempt after he won the Super Bowl, right? Everyone else is happy. Why am I not happy, right? I achieve, and I still don't feel good. Yeah. You can have that distortion. It can be very motivating in the moment, but when you reach a certain level of success and you're still not happy, it can influence profound depressive ideology.
So
I even think that feeling bad can be a motivator to really achieve, thinking that that's the answer, that's your solution. I think, just personally, the times in my life when I probably felt the worst are the times when I've achieved the most. And so I think to be really cautious of if you look at the people who are getting all the applause, why do they need that?
So we have a lot of marketing dollars behind pharmaceuticals in America. So everybody knows about the medications. They see it on their TV. Their physicians know about it. But there's no marketing dollars for cognitive behavioral therapy and how effective that can be. And sometimes making medications unnecessary. Can you guys talk about cognitive behavioral therapy?
Sure.
Any one of you?
Yeah, sure. What is very exciting on this front, if you look at New York Times, 2 or 3 weeks ago, they had that big expose on the epidemic of mental health issues among teens. And they did have the entire section dedicated to specifically skills-based interventions, cognitive behavioral therapy, DBT-related strategies, right?
Interpersonal therapy.
I loved the final hopeless paragraph, final summary of the article. Is that traditionally, he said, my generation, we had a midlife crisis, and we waited till we were in our 50s to learn these skills and to do these kind of things. What if we have an entire generation that's now learning them as teens or preteens, right? So CBT is essentially giving you some skills to challenge the distorted thinking we have that can influence feelings of depression. Don't get me wrong, you're still going to hurt when painful things happen, but we're not going to be less inclined to magnify and less inclined to see them as permanent and actively engage in those wonderful kind of happiness, positive psychology interventions that we were just talking about, and have those behaviors reinforced for us by people in our environment, by our clinician. And that part, if we could take that away, if now people are going to get interventions and skills earlier, that's going to be carried throughout their lifespan, which is exciting.
It is. Yeah, I love CBT. I use CBT every day. I think just for people who don't know, cognitive behavioral therapy is thoughts lead to feelings and feelings lead to action. And so if there's something that you're not doing that you'd like to do, like that exercise increase serotonin, or that you are doing that you'd like to stop doing, well, any behavioral pattern has a link to your feelings. So you're always trying to manage your feelings without even knowing it. So any feeling can't happen without having a thought first. So it always goes thought, feeling, action, thought, feeling, action. So if we have these unwanted feelings, we have to go to the thought. And so a lot of the thinking, we call it stinking thinking. Our thoughts aren't facts. And so we can change the way that we think to change the way that we feel, and then do all the things that make us proud to be ourselves. And so, kind of behavioral therapy, it works, and so I think that's always the go-to. So we start with lifestyle, the eat, sleep, exercise, and then shift to kind of behavioral work. And people stick with it. It's not an overnight solution, but if people stick with it, in probably about 4 weeks or so, we can see that shift,
One of the things that we are introducing in schools are curriculums designed to help children learn to self-monitor and self-regulate as early
Way
as
overdue,
kindergarten.
Way overdue.
Yeah, and so many schools are implementing that now. It's not just for children with reactive issues in the moment, but to help be a preventative measure, a proactive measure to teach all kids about how they think, how they feel, and their behaviors and how they're related, interrelated. So yeah, that's pretty exciting. What's happening.
Speaking of something exciting, on October 6th, across the country, and here at Marywood also, there's going to be a screening event for depression and related problems. Dr. Schaefer, you're going to be directing one of those efforts. Can you describe what's involved?
Absolutely. It is an exciting time. So we do this annually. Anyone from the community, anyone from our student population, they can come to the Psychological Services Center. There'll be a graduate student there that will escort you to a room. You'll fill out a fairly brief screener. We'll score that screener for you, let you know if there's any concerns related to depression. If there are, and you're interested in services, we can get you set up here or somewhere else with an appointment to have ongoing services. Last year we had our largest turnout in some time, so we had over 117, I believe, people that came in to be evaluated. And anyone who had a positive screening had access to services. And this is regardless of your ability to pay. My clinic, Psychological Services Center, it is services done gratis, so it will cost you nothing. You will not be turned away based on your ability to pay. The screening itself is completely free as well.
And what kind of information do people have to give about themselves when they come in?
Thank you. So it's no personal information. No one's going to ask for your ID. No one's going to ask for where you
Completely
live.
anonymous.
You're simply going to be greeted. I noticed I told you the number of people that came in. I didn't tell you the number of people that entered services because I don't know. We don't track anything beyond the total number, and we can only do that because we can count the number of sheets that people filled out.
So what would you say is the average amount of time investment people need to give to this?
Yes, there's a high volume time. There's some students that don't have courses between 1 and 2, so that's a high volume time. Outside of that, it's 15 minutes in and out.
15 minutes. Free parking?
Absolutely. There's we
No
have designated
charge.
parking for people coming to the clinic, and it's what, maybe 50 feet to enter. We're
Wheelchair accessible?
wheelchair accessible, and there's handicap spaces as well.
So free, brief, anonymous, and then there's the option of receiving referral for some treatments that themselves have no charge.
Correct. And someone could have a very high screening score and elect not to engage in services, and that's totally fine too. You can leave with places that you can choose to access service with when you feel it's best for you.
So the number there, and I'm sure our leader here, Mr. Mangoni, will have this on the screen at some point, but it's 570-348-1111. 6269. People can call that number. So for you guys, let's say, I'm sure you run into people who think it'd be good if my husband went for this, or it'd be good if my best friend went for this. Do you have any advice for people watching who have a loved one they want to see bring in, but they're not sure how to approach them about it?
I have an idea. So I've often had family members, talk with me and say, we'll do let's say I do it with a kid, and I'll do several rating scales and come to a diagnosis, and it'll be major depressive disorder. And so I'll meet with the parents and say, okay, we've come to the conclusion, and these are the things that we found, and, the diagnosis is depression. And they'll say, do you think we have to tell her? And I'm like, I think she knows. And so, for family members who are afraid to say, hey, why don't we go give a name to this thing? The person that you're worried you're going to offend is the one in pain. They know they're in pain. And so I would say, hey, I've noticed that, you've had these behaviors or these different changes in your, daily activities or your patterns. It seems like you've been upset lately. There's this place that we can go, and they're going to be able to identify this problem, and then we're going to be able to hop in the solution, and we're going to do it together. Great.
Another idea is to say, hey, I'd like to go to the screening event. Would you keep me company? Little subterfuge there. So I want to give you each a chance to give a closing remark. I'm going to go last with you, Dr. Badner, so you can talk about your service you have to offer in the spring. Cindy, you have a closing thought you'd like to share? Anything at all?
Definitely the fact that, at least for my experience as a college student, depression and just mental health problems and issues and concerns have been so downplayed and normalized in the college community, and I think even in just adolescence, young adulthood, because everyone's just so used to, oh, it could be worse, I'll get better, and I just need to focus on my life, my schoolwork, my education, everything. But it all comes from you. If you are not well, and if you are not feeling like yourself, there's no way you can strive for excellence and be your best self. So I just think taking that extra step for self-care and just prioritizing yourself is so important.
I think, so my closing thought would be, we have solutions for these problems. And so, the hopelessness comes from thinking that this is never going to change. It just takes, what I like to say with my clients is, just one tweak a week. That's all we're asking here. Just one tweak, one change in your behavior each week. And the first step to doing that is getting an evaluation. And with it being free here, there's a really nice opportunity to do that.
And I think, too, on a personal note, in 2020, we had a graduate student that died by suicide. That was my graduate assistant, Brianna Ray Cruz. Wonderful, wonderful woman, wonderful family. And as I was going here today, and as we're talking, she's paramount in my thoughts. And I just wanted to let the community know that these services are available, and that there's good people, not just here at my clinic, but good people here on the panel, good people all in the community that are there to help you and your family. And like you said, if someone's not getting services and you're very concerned about them, you can reach out and come and have conversations. You can have a few sessions with a professional that can help you encourage that person to access services and process your own stress in dealing with those situations. These issues don't just impact the individual, they permeate throughout all the people that touch the lives of these individuals.
Dr. Badger, before you give your closing thought, I just want to say I think you have spectacular taste in jackets. Please.
Yes, I believe you do as well. So yes, for one thing I would stress is for parents, for teachers, if you're noticing a significant change in your child's or student's mood or their behavior. We all go through changes or in how we feel and what we think for short periods of time. But if it's going on 2 weeks, 3 weeks period of time, take it seriously. Ask questions. Find out more from that child, for your child or your student. You seem more sad lately, or what's that about? Start asking questions. Parents, follow up with a trusted adult in school, maybe that student's child's teacher. Teachers, check in with the family, see if anything like this is going on at home. And also for the student, oftentimes they encounter other friends or acquaintances in school that they have concerns about, that they hear this child talking about. Talk to a trusted adult at the school as well, a guidance counselor, a school counselor, someone, or some schools have drop boxes where they can fill out a index card on a concern of a student. Then that goes to the student assistance team, the SAP program, and they'll follow up at that point from an anonymous drop there. But each school is different.
Thank you.
So definitely follow up. In terms of what we offer our community, our local community surrounding Marywood, is psychoeducational evaluations starting in the spring. So if you're a parent who has a concern about your child's behavior in school or academics in school, this is something that we can provide an evaluation for.
Thank you. And they call that same number.
Call the same number. It's at the Psychological Services Center for a very nominal fee.
Thank you. Thank you all for coming. That's it for this edition of Mental Health Matters. I'd like to thank our crack team behind the camera, Tom O'Keefe, Rebecca Loscombe, and Kyle Driscoll, as well as Mr. Mangoni, our master and commander of all things Mental Health Matters. Please do tune in next month when our topic is going to be cultural stresses, the different stresses we're all dealing with. Until then, please remember, mental health matters.